Welcome, I am Fabiola Molina, physiotherapist, and today, I am here to tell you about the case of a 63-year-old woman with rheumatoid arthritis who we have been able to help with a passive treatment with Nesa. She came to the clinic on a recommendation, and on the first day we carried out an anamnesis in which she told us and gave us information about her situation. Diagnosed with rheumatoid arthritis since 2014, she suffers from joint pain, especially in her hands, where you can see and appreciate the typical hands with the fingers in bursts, and also in her knee, which makes it difficult for her to walk. She uses trekking poles with 2 poles to help her walk. In addition, the patient has a history of several oncological processes. At the present time, she has sleep problems, restless leg syndrome, fatigue, and refers to weakness of the lower limbs. She is taking corticoids for her rheumatic disease and benzodiazepines to sleep. The patient has a very good predisposition. She makes an effort to exercise daily despite the difficulties. She has and takes care of her diet. Once all this information has been collected, a global vision of the organism is explained to her from the point of view of the autonomic nervous system, and how her quality of life can be improved by modulating the nervous system, optimizing her body's resources. Logically, we also explain the limitations of the technology, where we are not going to be able to help you and in which aspects we can. For example, the perception of symptoms, your quality of life, and your quality of sleep. Given your illnesses, this treatment is totally palliative and the improvements you achieve will probably be lost over time, once the session is over. I must emphasize that this patient, a psychologist by profession, despite her skepticism, showed a magnificent willingness to be helped from the beginning. Something we have already seen in the past as a clear enhancer of microcurrents. I think that in general for any technique we apply, we negotiate the objectives with her based on the real possibility of the technology. And we decide to try to improve, on the one hand, the generalized pain she suffers, and on the other hand, the quality of her sleep. In order to be able to measure these 2 objectives, and in general the evolution that the patient may feel, she is given a WICardio. We measure her general quality of life with a Eurocall questionnaire, and the quality of her sleep with a Pittsburgh. In order to assess pain, we also use the Latanan chronic pain scale, and another pain catastrophization scale. The treatment starts intensively. The first weeks we see her 4 times, the second week 3 times and the third week 3 times to ensure that she notices a change in a short period of time. In this particular case, the patient reported improvements in her sleep from the first week. In our clinic we have a protocol for giving a series of information to the patient each time they start, and one of them is the possibility of experiencing pinching, cramps, or pain in areas where they normally or previously have had lesions or pain. It is not common for this to happen, but in this case the patient noticed during the first 3 sessions in specific areas where she had had tube rations from the oncological process, certain pricks. Having warned her and prevented it from the beginning and sometimes explained it properly, the patient interprets this as something normal and does not give it much importance. From the 3rd session onwards, she began to notice an improvement in the usual pain in her wrists, but not in the rest of the pain, which remained as usual for her. During the first sessions, she noticed a clear improvement in the quality of her sleep and a slight reduction in her pain, especially in terms of the location of the pain. The next 10 sessions were held twice a week, focusing on fatigue, and she began to improve her walking. She even refers to not needing the canes at times, which was not the case before. How do we achieve this? In the first sessions we apply central and general programs in order to be gentler in this first contact of the patient with the microcurrents, placing the directioner administered at C7. We use a program 1, a program 7 and a program 8. Then we continue with central sessions, with a program 2 alternated with a program 5 or 6 and a 7 and an 8, all at 15 minutes. By mixing the programs and putting a little bit of each one, we are more progressive with the treatment. During the last sessions of this first voucher of 10, the patient comes to the clinic with intense discomfort in her stomach. Similar, as she explains to us, to some discomfort she had suffered years before. So, reasoning that it may have something to do with the therapeutic target, we applied the directional electrode at the level of the mesenteric plexus, 4 fingers above the navel with a program 2 and a program 7 for 45 minutes, i.e. 75% of the time with a program 7. The times are detailed in the image you can see on the screen. After this session in the abdominal area, the patient has a significant improvement in the generalized pain she was suffering from. So it is interesting for us to repeat the sessions with the same programming for 4 more days. This patient has been coming to our clinic in Tenerife once a week for more than 10 months now. It is difficult to explain in an educational video like this one why we put each program, configuration, every day for such a long time. But I can explain that from the 3rd voucher onwards we varied between the days when I had more localized pain with a program 6, the days with more fatigue with program 5, and the days when we wanted to affect the autonomic nervous system, anxiety, sleep or systemic pain with a program 7. After 4 months of treatment, we went through the forms again. His quality of life improved by 20% of the total value with the Eurocall questionnaire, also known as the EQ5D, and his chronic pain did not improve significantly. In a second part, the questionnaires were repeated. After 8 months of treatment, the improvement in sleep was maintained, the quality of life increased even more to 30% of the baseline value, and the intensity with which the pain was perceived began to decrease. This data was acquired through the Latin Chronic Pain Questionnaire. Remember that you can access all the questionnaires here on the Clinical Guidelines campus to implement it in your workplace. Each language has its specific questionnaires, some common to each other and some not. Keep in mind, there is no programming for rheumatoid arthritis. And I will repeat, there is no standard programming for rheumatoid arthritis. Why? Because all arthritis is different. You need to personalize the treatment by talking to the patient day by day, week by week. Remember this important quote from Hippocrates who said, "It is much more important to know which person has the disease than which disease the person has." Thank you very much. I hope my experience has been helpful to you. See you in the next video.